Hello, I'm Alan Jarmias from St. Francis Hospital in New York, and I'm here today with Rasha Alami from Imperial College in London. And I think what we're going to talk about today is this new concept using physiology more for lesion guidance than just ischemia detection. I think you do this in your practice also quite frequently, from what I understand. So why don't we talk a little bit about how you approach PCI or how you approach lesion assessment altogether with the use of physiology, patient that you see, let's say, with a intermediate lesion.
Yeah, so thank you, Alan. But I think one of the things I find at the moment is the guidelines are actually quite limiting in where the role of physiology is. It's all about intermediate lesions, make a diagnosis, should you treat, shouldn't you treat? And that's kind of not how we practice now in our lab. Most of our patients come to us usually from a CT pathway. We've already determined that they have anatomically severe or at least moderate coronary artery disease. Most of them hopefully have had some kind of symptom assessment. Some of them have even had an ischemia test. And by the time they get to the lab, the question of should we treat has kind of already been made. Now we're making a decision about how we treat the patients. And that's where physiology, I think, really can give us a lot. Obviously also often in combination with intravascular imaging. So in our lab, we use, in most patients, the vast majority, physiology to guide our PCI. And what we're doing here is we're taking a spot measurement because we have the option to do that always.
Of course.
And then we're using pullback, often with co-registration, to try and see, is this focal disease? Is it diffuse disease? Is it more often than not mixed disease? And especially in mixed disease, we then use intravascular imaging to have a think about where we're going to land our stents. We usually often use intravascular imaging to obviously plaque characterize, decide how we're going to do the plaque preparation. And then with the two in combination, we think about our result. So as much as possible, we're trying to do post-PCI physiology and then obviously lots of post-PCI IVUS. And I would say in terms of rates in our lab, we probably use physiology in at least upfront, at least 80% of our PCI, especially in stable patients, maybe even more. And then post-PCI, we're probably not as good. We do it in every research case, but probably about 40% of the cases that are clinical.
Right. I mean, that's still pretty impressive. And I would say it's really moving the needle on how we use physiology. Just like you mentioned, the guidelines may not have fully, caught up yet to this kind of strategy. So as you know, I'm one of the people running Define GPS, which is kind of a trial looking at exactly that strategy. And so as we have been developing that, within the trial, we try to kind of adopt from the imaging world the MLD max strategy to physiology, similar to what you have been describing. And so the nomenclature now, if you will, is called Act 1 and Act 2, right? So maybe we should go through that in a bit more detail, what you'd have described before. So A stands for assessment.
Yeah, well, firstly, I start with Act 1. Act 2 is very nice, very Hollywood, so we like that very much, so thank you.
I mean, you're glamorous.
And something we'll never forget. And Act 1 is really the bit where we assess, take that spot measurement, we work out what the physiology is.
So that's typically a distal measurement, right?
Yeah.
How far down do you put the wire?
So, I go at least 3 vessel diameters distal to the most distal lesion that I care about. So I don't go necessarily all the way down to the apex if it's the LAD or whatever it might be. But I go to the point at which I think there's laminar flow away from that lesion where there isn't turbulence that might affect my physiological measurement.
And you do IFR typically?
And typically we do IFR. In the vast majority of cases, we're happy that IFR it gives us what we need.
You don't give adenosine?
We very rarely give adenosine. In research cases, I do it in 100%, but in the clinical cases, it's mainly IFR. Then as part of my assessment, pullback is a key bit. We're always going to do a drift check. And so as we do that drift check, it's important to have that extra bit of information. As I've said, the pullback information is more important to me these days than that spot measurement.
That's a C.
Well, it's
almost
absolutely part of it's that standard for me. The extra bit of the C is co-registration.
Right.
That you can kind of get for free now because you've used the last angiogram, so you don't even have to deliver contrast again.
So that's a software called Sync Vision.
Yeah.
Right. And so with the Sync Vision, you can co-register the physiology, which basically indicates a pressure loss throughout the vessel. With the yellow dots, as you well know, each dot represents 0.01 units of IFR, pressure loss basically. And and the same with imaging, right?
Yeah, and that co-registration map is very intuitive. So you and others have sort of determined how we should use it. But fundamentally, where there's lots of focal loss, I'm going to call this focal disease,
Right.
and where it's incredibly diffuse all the way down the vessel, that's kind of important, because in those cases, often I decide not to treat at all. And then we have that kind of mixed disease. Then the T is...
1 second before we go
Yeah.
to the T, I think one important feature of the software we should probably highlight is maybe part of the C still is the procedure planning.
Oh, yeah.
So maybe talk about
So
that.
we use that a lot. So that kind of virtual PCI.
Right.
What we usually do at that point is either one of our technicians or myself in the lab think about where we're going to land a stent, how long that stent needs to be. Often we've also done tri-registration at that point, so we also have IBIS imaging. And together, what we decide then is what's going to be the gain in terms of IFR units if we stent a certain area. And importantly, we're trying to minimize the lengths of our stents, and we're trying to, using the IBIS, get those stents as big as possible.
Right.
Now, the software obviously tells us what gain we'll get from the best possible PCI. We don't always achieve that, but we try our very best. And then obviously we get into the T, which is the treat.
Exactly. Well, at least I think this is very, very important, because as opposed to kind of going in blindly and then figuring out, oh, you know what, we put a stent, but it didn't really help that much. You have an idea before you do anything, and potentially you can also make the decision to say, look, maybe the stent is not a right choice here, maybe send the patient to surgery or treat him medically. So you can still make decisions at this point because you haven't really started the intervention yet.
Totally. I mean, that concept, it's an old-fashioned thing of, you put the stent in badly and now you're stuck, right? We can't delete it.
You can't take it out.
It's too late.
Right.
You're not extracting this thing. You've, potentially done harm, actually, when you've done it wrong.
Not potentially, you've done harm.
Yeah. So
You're too polite.
I am polite.
You're too English.
That's so Francis way. So I'm going to say...
We're New Yorkers,
Yeah.
man. We say
Yeah.
it the way it is.
Yeah. So I'm going to say, you've not necessarily done the right thing for your patient that day. And so you need to know before you do it.
Right, 100%.
And then there's the
Then we get to Act 2.
Act 2, which I like very much. Act 2 is the bit where very often people aren't doing it, right?
Yes.
And we're trying to get to a point where we do it. We used to say, I don't want to assess post-PCI physiology because it's likely that it's very diffuse disease, there's nothing to treat. Or more importantly, for lots of people, I don't want to know if the physiological result is bad. But you've taught us that in around a quarter of patients, if we do post-PCI physiology, we will find that it's inadequate,
Right.
although we don't quite know what the target should be.
Now, that was not guided by Act 1, in all fairness. So
Yeah.
in theory, the idea being, if you do the pre-physiology, the planning the way you described, you should not have 25% of residual
Totally.
ischemic patients. But you obviously don't know.
Who knows? We'll see from Define
Right.
GPS,
We're
right?
gonna find out.
And then with that 25%, obviously a significant proportion, 3/4 of them, often have some kind of focal
Something
problem.
you can address.
An underexpanded stent, a bit of plaque at the, plaque burden at the edges that you've not treated, something you can now fix. So Act 2 involves assess again, co-register again if
Right.
needed, and if needed, treat again, right? Do something else to make things better. And hopefully you're going to get better symptom response with, best practice PCI.
So it's very similar in a way to MLD Max, right? We're looking at maybe different things, but it's kind of the physiology equivalent of MLD Max, which is what the idea is. And
I've
frequently,
worked out you really like 3-letter acronyms. That's
well,
how
I
it
couldn't,
works.
I couldn't think of a second, third one. So with this, why Act 1 and Act 2 came about. But frequently we also, as you say, combine it with imaging. I think at St. Francis we image basically everybody. I don't think the two are mutually exclusive. I think frequently they actually help, to kind of come up with the best plan.
Yeah, that thing that we used to have debates. In fact, years ago, I remember debating Ziad, I'm for physiology, he's for imaging. It's a ridiculous debate these days, right?
Right.
I think, why are you going to, if you can, have two,
Yes.
you want both, right?
Yes.
Of course, there are cost constraints in some systems where that's not possible. In my system, I'm able to use both as liberally as I like. And for me, if I had BCI, that's what I'd want the
100%.
interventionist to do.
Now let's talk a little bit about disease pattern. I think that's kind of important, right? This is why we do the pullback and the co-registration to understand, is it focal, multifocal, focal diffuse, just diffuse? I understand you did some research.
Yeah, so we've done quite a bit of this. We did research like this in Orbital 1. We looked at pattern of disease and how it predicted the benefit from PCI. In Orbital 1, as you remember, the symptom response from PCI on maximal anti-anginal therapy was not what we'd expected versus a placebo procedure. So we were kind of always underpowered to look at symptom endpoints. But what we found there was that in a focal lesion with best practice PCI, you were most likely to get ischemia improvement on stress echo versus a placebo procedure.
Right.
Now what we've done is an analysis from Orbiter 2, where of course we had symptom response with PCI off anti-anginal therapy. We were much better powered to be able to look at different endpoints, especially because we had a daily longitudinal collection of angina on the app. And what we found, and it's coming out in a journal, I'm going to say a major journal near you very soon, is that with focal lesions, you can very predictably see symptom response with good PCI. For diffuse disease, interestingly, PCI is like a placebo procedure. It's really not going to do what you want in terms of symptom benefit. So it's another moment where we might start to consider that once, doesn't matter what your IFR is, if you've got diffuse disease or FFR for that matter, you probably are better leaving that patient with conservative management.
Let me ask you this
therapy.
though. Does it not depend on IFR gain? Like obviously with focal disease, you theoretically going to have more gain. Now, if you treat diffuse disease adequately, you might also have significant IFR gain. It's only when you treat diffuse disease inadequately that you maybe run into problems.
Maybe. That's hard for us to know. I think gain is a key. So if you take someone from IFR of 0.4 to an IFR of 0.85, you've not got over the ischemia threshold, but you've made significant gain. I actually think they get pretty good symptom improvement. If you take them from 0.88 to a 0.91 IFR, I'm not sure they get symptom improvement, even if they cross the cut point. To your point, maybe long, very diffuse disease, if you got them to a decent IFR or FFR, you might have symptom improvement. My worry on that is there will be a trade-off, right? Very long stents into the smaller aspects of the vessel.
Maybe in the future.
Perhaps DCB. We're long away from understanding if we give people lots and lots of treatment. We've already seen full metal jackets aren't good for patients. So I don't know, maybe there's an option of the kind of leave nothing behind strategies that helps us there.
I mean, I think there are also a little bit different patient populations. Certainly when one has maybe more lipidic plaque, more acute type of presentation, somebody more chronic angina, more calcific plaque, obviously more difficult to treat. So I think we need maybe better treatment options for those patients with diffuse disease.
Which we're starting to get, right? And so, okay, we've got our lab treatment options and they're getting better, but actually our preventative therapies, I mean, you know, the wealth of different therapies that we have at our disposal is increasing.
For sure.
What I'd like to see more in the future is interventional cardiologists being part of the preventative pathway, right? You've stented a patient today, or maybe you haven't. I mean, it's for us to say what kind of prevention we need to see these patients on. They're much more likely to take it if we tell them to do it.
Right.
And actually, their primary care physicians and the wider team are likely to take instruction from us, right?
I think, that's probably true. So congratulations on this publication.
Thank you.
Looking forward to see it in print. Any other tips and tricks, I guess, and in terms of, you know, how to accomplish this in your lab? I mean, I know there's some resistance also from maybe the nurses. You know, it takes extra time, extra effort. How would you recommend people who are interested should go about implementing this?
So, I mean, the first thing I say is it doesn't take that much extra time. It takes loads of time when you're like deliberating, taking lots and lots of different angio images,
opinions, walking around,
coming
getting
outside,
opinions,
trying to find people still dressed in your scrubs, trying to find someone to speak to you and look at an angiogram image. That takes plenty of time, right? You do a decent IFR co-registration, maybe you've added IVUS and you've got tri-registration. You use the software, which will increasingly have more AI capacity to help us predict what we should do. You kind of make a decision pretty quickly. You can predict what your result is. Hopefully, in the vast majority of cases, your co-registration works. You don't have problems with that. and then you get a result that's predictable. So I don't think it adds extra
You
time.
don't think it adds time?
No, one of the things we've done in our lab, and I know you've done the same, is our wider allied healthcare professionals have all gone on training courses. They've all learned
Right, I
how
think
to do
that's
this.
critical.
So they're not, they know to get things set up as soon as I come in to do a case. And they're not disappointed when I say, we're going to do extra bits. They just know it's part of the procedure.
Right. They know you're difficult.
I mean, you know me, I'm slightly precious.
Now, that said, what I like about this whole concept is it really eliminates certainly the guessing, but also a lot of the thinking. Because once you go through the motion and you do all of these steps, which after you've done 10, 15, 20 cases, I think you're pretty facile. It doesn't really add a lot of time, like you say. And really the whole PCI plan is kind of mapped out for you. So a lot of the extra thinking and energy on what to do kind of goes away, and you basically execute like a robot.
I mean, arguably, you're kind of an automaton just
Right.
getting on with the procedure,
That's
right?
it.
But, I know we always make this analogy with pilots, right? But ultimately, if you're sitting on a plane, you want the person in the cockpit to actually act like an automaton. I'd be happier with them doing that. And I always find it very unusual that, and kind of substandard, that in the same place, in parallel labs, people are doing totally
Right.
different things.
And then different labs forget about it.
I mean, it's
There's
crazy, right?
There's no standardization
There's no
really of interventional cardiology care.
Yeah, and that our patients would not expect that, right?
Right.
They wouldn't know that if they came into my lab, they'd get a very different procedure to another lab, to the basics of even just the kit you use, right? Never mind operator ability, etc.
Sure.
So in some labs, you're going in and there are still people direct stenting and not post-dilating, right? And I don't think that that's the way we should be. I think we should have some level of standardization of care, albeit that everyone wants their own decision making within it, but there should be some basics that are fundamental and mandatory.
Philips.